Welcome to our presentation of psychological disorders, or psychopathology, where we'll discuss what they are, how we diagnose them, and also engage and dig deeper into the debate about how we might be able to do this better. This and more coming up. As you can see, first we have to understand the taxonomy, the procedures, and the training that's involved with doing diagnosing of psychological disorders. And I should point out that my specialty in my doctoral training is in industrial organizational psychology, as I've said before, which means I don't have any special expertise at the graduate level in understanding psychological disorders or doing therapy or diagnosing. So I can only offer maybe informal discussions and point you in the right way if you or somebody you know are dealing with a psychological disorder and need professional assistance. But we can join in the discussion about trying to understand what are some of the limitations with the system as it is. What are some alternatives potentially, and why might they be better, and what might be the problems associated with that? But first, some true-false. It might be tempting to think that diagnoses are unreliable. You might have heard some stories about somebody being diagnosed with ADHD, for example, and then go to another physician or a clinician and find out that the diagnosis does not replicate. However, in most cases, this is false. There's a wide variability in terms of how reliable and valid a diagnosis is. Some schizophrenia are highly reliable. Almost everybody who's had training knows it when they see it. Others, and some of the emerging psychological disorders, maybe have lower reliability just due to the fact that we are still learning about them. But they have to meet certain thresholds to even be in the game in terms of being diagnosable. Hallucinations might sound like an indication of serious mental illness, and for some, such as schizophrenia again, can be a strong symptom. But it's also important to note that by itself, one symptom is rarely going to be enough to result in a diagnosis. And in fact, many people report hallucinations who have no psychological disorder. You might think that children are happy and haven't been ruined by the dangers of the world, that they are not capable of being severely depressed. But in fact, this is true. There is debate in terms of taking psychological disorders that are typically researched and applied to adults, and then setting that down for children. And of course, we have to have research to show that depression in children is also a real thing. We can't just say it happens in adults, so it also happens in children, for example. With psychological disorders, we know there's a risk of suicide, particularly a few in particular that we'll talk about. There's often the belief that people who talk about suicide rarely follow through and actually do it. They're seeking attention. This is actually false. Talking about suicide is one of the largest predictors of somebody actually committing suicide. Of course, it's not perfect. You have some false positives, but it is an important sign or symptom to consider. We might think that depression is characterized by extreme sadness, but once again, that one thing or symptom is not by itself enough to lead to a diagnosis. So it is possible for people to have major depressive disorder and not feel extreme sadness, but instead what's called anhedonia, and feel no satisfaction in things that other people would find satisfaction with in life. You might think that adolescence, with some of the things that we hear, some of the movies we see in pop culture, that adolescence is the age group where suicide is the biggest risk. But that is untrue. It's actually the elderly, where the risk for suicide, especially for elderly males, is extremely high. For our key concept, let's distinguish between what are psychological disorders and what are things that might sort of look like them, but are not in the big book of psychological disorders that we'll talk about. If you think about obesity, mostly considered a medical issue, right? We take medical measurements such as height and weight and use this imperfect measure of body mass index. And that calculates whether somebody is overweight or obese or healthy. But in fact, if you think about what does obesity look like mentally, How do they think? How do they behave? And how do those interact? Then we can maybe see some similarities to a psychological disorder. Think about somebody who's obese. They probably spend more of their day thinking about food. That also applies to anorexia on the other side of the scale. You might think people who are anorexic don't have an appetite, but in fact, they spend more time fixating on food, thinking about food, than psychologically healthy people. So what this leads us to believe is that, especially we've often thought about the medical community and the psychological community as separate, but in many things they have overlap. And I think we're seeing a lot of progress lately in getting those two fields to acknowledge that they're both important and that they need to work together. As we continue to set the background for our discussion of psychological disorders, let's look at some statistics to give us some perspective about the scope of the issue. If we think about any given year, usually for serious or severe psychological illness, which require inpatient admissions, there are over 2 million per year. Now the question is, does that reflect the true base rate or incidence of these psychiatric admissions, or do they underrepresent and there are actually more people out there who need inpatient treatment who are not able to receive it? And if you think about the total number of beds available, they're much less than 2 million. You can see they're a few 100,000 at any given time. But of course, there's not just the inpatient treatment, there's also outpatient services too, and we can see that many more seek outpatient services. Once again, we have the same issue. Does this represent the true number of people who should seek outpatient services? And this final stat kind of shows that probably not. These stats underrepresent the total number of people who might need psychological services. So for example, if we take 300 million plus Americans, and perhaps 20% of them might need some form of psychological help, certainly not 20% that would require severe or inpatient treatment, whether long-standing, more permanent arrangements or acute, a couple weeks or a month here or there. 20% of 300 million is a large number, and we could make the argument that we don't have necessarily the infrastructure that we should have to deal with these issues. We also can talk about the controversy regarding what it means to label somebody. And of course, using our stereotyping or top-down processing that we've learned about through the semester, once we know what something is semantically, that guides our expectations and our judgments of that person's thinking and behavior thereafter. So Rosenhan did what was a very attention-getting study. It wasn't great in terms of using the statistics and the methods, but it got a lot of attention. Basically, he had some of his graduate students and himself report to psychiatric hospitals saying that they were hearing voices and that the voices said things like hollow, dull, and thud. So they weren't saying to kill people or that they were going to commit suicide. They were just saying these sort of inane words. But hearing voices is a sign of a hallucination or a kind of hallucination. And for most clinicians, that's an indicator, potentially, of schizophrenia. So all of these people were admitted to the psychiatric hospitals, and then after that, they behaved completely normally. However, as you can see, it took about 19 days on average for the staff there to, you could argue, realize that their initial diagnosis was incorrect. Now, Rosenhan said that no one was released with a diagnosis of sane. Instead, they were released with a diagnosis of schizophrenia in remission. Now that might sound bad, and that's what the popular culture view of this study was. Wow, they didn't even realize that there was nothing wrong with them. But you can also argue that the diagnosis of schizophrenia in remission is very rare. And so for those people to get this different diagnosis that you almost never see otherwise could also be argued as an indication that the staff at these hospitals did see that these people were different over the course of a few weeks compared to a person with traditional schizophrenic signs. And here you can see the opinion on this issue about the dangerous, potentially, effects of stigmatizing regarding psychological diagnoses with one of my favorite clinical psychologists, Scott Lilienfeld, a person who has really influenced a lot of how I set up this course, some of my true-false questions, and he'll have more to say about this at the end of our slideshow. But basically, you can see he's making the argument that, look, the way we do it isn't perfect, and we have to keep trying to improve the system, which is often done. This is part of the scientific process. This is part of how we'll talk about what the DSM is in just a second, how we can make it better. But just saying that stigmatizing through diagnosing, labeling somebody as a manic depressive or having bipolar, for example, is counterproductive, because if we don't use a label, it's hard to lead to treatment that will help this person. So what Lilienfeld instead argues is that the problem is not with diagnosing and labeling itself. The problem is with community education in terms of not really understanding what it means to have bipolar, what it means to have major depression, what it means to have antisocial personality. And I think there's a lot of extra fear that comes with knowing someone has a diagnosis that probably shouldn't be there if we really understood better what it's like to live with that illness. But let's talk about what are some of the defining features of what we can call a psychological disorder. So in no case is a psychological disorder just made up by a group of people and then put in the big book of diagnoses. It has to meet a lot of criteria just to even meet discussion for inclusion. So first of all, we have to see it's deviant. That means it's different. Of course, that can't be enough in itself. Otherwise, we would basically be punishing any minority group in this country for being different and labeling them with a disorder. It also has to be distressful. And of course, what is distressful in the US might not be distressful in other cultures. So for example, speaking in tongues, if somebody did it in a classroom, would seem very strange. If somebody did it in certain religious ceremonies, it would not seem distressful. There also has to be some aspect of dysfunction. So that means a person can be different, and that means it can look strange and think that they're having trouble dealing with that. Other people find it troublesome. But it also has to involve some level of harm, some level of dysfunction that is abnormal. It also has to be unjustifiable. So for example, part of the diagnosis of psychological disorders involves ruling out alternative causes. So for example, somebody could be hallucinating and you might think schizophrenia, but then you find out that they're abusing substances. And so you can't really make a diagnosis until they are clean enough so that you see whether the symptoms show up in the absence of the substance abuse. We also need to think about the historical perspective in terms of how we do diagnosing. So once again, a common theme is that we can do it better. And many of you might not be satisfied with the current state of events, but our perspective shows us that I think it's much better than it used to be 500 years ago. So for example, lunacy derives from the word full moon, with this common belief that people start to act more crazy or show more signs of psychological distress or disorder under full moons. Research really hasn't shown or supported that much. Also causes would be evil spirits. If somebody was possessed by an evil spirit, that could cause them to act strangely and distressfully. And of course, if we think, what is going on? There's research to show that there's a drastic rise in exorcisms, mass exorcisms. Lots of people just saying, I think there's something wrong with me. What this goes to show is that the psychological disorders have existed for a long time, and people typically reach out in some ways to deal with it. What we need is to have a system to show treatments and offer treatments that have research to back them. Because if we don't, people might find their own treatments that they think are useful, which in most cases probably will not address the root cause. And if they work, would only work through placebo means. And of course, you can see some of these other treatments sound pretty drastic. Looking at maybe the Salem witch trials and other examples of mass hysteria. And you could have the theory that, well, if you have bad blood, You need to get that replaced, sucked out by leeches. And some of our founding fathers, in fact, believed in these treatments. It just goes to show that, once again, what seems like a psychological disorder is not universal across time and across countries, and it has to be considered in the context of time and country. We can also look for some explanations of why do psychological disorders come out? Why do they happen? Why do they occur? Traditionally, in the past, we have relied more on the medical model. And you can argue that, for example, from Freudian times, we're looking at unconscious explanations, which were not perfect, but certainly an improvement from the belief in possession by evil spirits and the position of the moon and stars. That gave rise to what we have now known as the medical model, the belief that through drugs, through understanding neuroscience and neurotransmitters, that we can really address all psychological disorders. Of course, that might seem ridiculous now, but in the 60s, there really was this belief that our brain is responsible for our thoughts and behavior, and if we can change different pathways, different neurotransmitter levels in the brain, we should be able to control and regulate the activities, the thoughts and behaviors of people with psychological disorders. And of course, we do have situations where medication is very important, and it's hard to distinguish between whether it should be a long-term situation to address people's neurotransmitter levels consistently, or if it's instead an acute situation where they're really dealing with stress, inability to sleep, or depression. And if you just help them medically in the moment for a couple weeks, a couple months, then quit the treatment, that will give them enough of a boost to do the rest themselves and get back to normal without the use of further medication. But of course, we have the alternative theory too. Conspiracy theories and skeptics say that, look, we see how big of an industry the pharmaceutical industry has become. And in many cases, you can make strong arguments that they are looking to prescribe drugs to people who don't need them. They are also looking to take drugs that have worked for one population, for example, schizophrenia, and apply it to another population, ADHD, without the research to show that this new population would respond positively to this treatment. So we always have to be somewhat skeptical of the pharmaceutical industry. And we, in terms of ourselves, if we're given a prescription, it's difficult for us to make the decision that we need the medication or not. So we need to ask questions of our doctors and our clinicians and our counselors to see what the real truth behind the prescription is. So I don't want to take the stance that drugs are bad all the time. For some people, they really help, whether it's long-term or acute. But it's important to ask the questions and think about, and maybe even look up some research yourself to find out whether you think that a certain medication that is being pushed on you is going to be helpful for your situation. And most importantly, we can't just think of the biological by itself. So for example, this is not in the textbook, but I think it's historically been very important, and it might be a little bit on the outs, but I wouldn't be surprised if it comes back in clinical settings. And it's fairly simple to understand. We have the biopsychosocial perspective. In some ways, we can call this a holistic understanding of a person. So of course, with a psychological disorder, there may be biological issues, such as neurochemistry or certain genes that suggest a predisposition for a certain psychological disorder. Knowing that is not enough, though, to be able to fully understand the situation or walk in somebody's shoes who has a psychological disorder. Because even if they're given predispositions, the cards are stacked against them in some ways, they can still change to some degree the way they think about their environments, the environments that they choose, how they perceive how people are interacting with them. Do we take a positive view or a negative view? Do we set goals or do we give up? And then finally, we have to consider the larger social context. So for example, somebody could have a genetic predisposition towards substance abuse, and they have a tendency to get very depressed when things aren't going well, which is a bad combination. That means that that person is at a huge risk for substance abuse, and we need to pay attention to the social environment that they find themselves in. We need to make sure that they have social support systems, for example, family, friends, church, counseling services available, so that when things get bad, the biological and the psychological tend to work against that person. We have the social aspect to bump them up and help them instead of forcing them to spiral out of control. So once again, I personally think the biopsychosocial model is very important for providing a context for a three-pronged understanding or a holistic understanding of the different things we need to think about when a diagnosis is given. As we've mentioned a couple times, when we're doing diagnosing, the most common technique in the US and other places of the world is the DSM, known as the Diagnostic and Statistical Manual of Mental Disorders, and you can see that it is written and published by the American Psychiatric Association, APA. It is a system for classifying and diagnosing psychological disorders, and you can see there's been a number of revisions since the first DSMs in the 1950s and 60s. I think this sets a really good example for a continuing to update how we think about psychological disorders. Once again, we can't just consider them independent of time, and one example would be in previous DSMs, homosexuality was a diagnosable psychological disorder. Of course, now we understand that differently, and we don't look at that in terms of psychological illness anymore. And the goal is to improve the reliability and the validity of diagnoses. To say, we're looking at all the research on a certain psychological disorder, such as panic attacks. This study shows that this symptom is linked to having this disorder. This other symptom looks like it's important from this other study, and these have been replicated by additional studies. What this results in is a list of potential criteria, diagnostic criteria, that indicate the possibility of having that disorder. And then you have to come up with a cutoff of maybe must meet 4 of 7 of these criteria to have initial diagnosis of the disorder. Once the initial diagnosis is made, then there are additional factors to consider. Using the biopsychosocial model, what are some situations that this person might be experiencing in their family or work life that will help to understand or put in context this single label or diagnosis. And as you can see, the newest model was released pretty recently in 2013. I have seen some of the changes. They make large sense to me, although I know there are still continuing debates about some of the mental illnesses in there. Now let's break down some specific general classes of disorders. And first we can start with anxiety disorders. As you can see, it involves stress, anxiety, and also behaviors. So the thinking, the fixation, the being scared, and also behaviors. What we do to relieve this anxiety. First, let's start with generalized anxiety disorder, oftentimes referred to by the initials GAD. This is a person who, if you know someone who is, you would describe as tightly wound, that would be someone with GAD, except GAD would be cranked up even tighter. Basically, they are always worrying about something. It affects their ability to sleep. So for example, they may be laying awake at night thinking about what their answer was to a question on the test the day before. And they're so fixated on it that they can't sleep until they send an email to try and ask what the right answer was. Did I get it right? And it's, of course, you can see this is maladaptive. It's intruding into this person's normal function. And you can think about the autonomic nervous system. What is the body doing in response to this generalized anxiety? Well, generalized elevated heart rate, generalized muscle tension, and things that correlate with that. We also have phobias. I assume most of us are familiar with what a phobia is. It's a consistent and, of course, irrational fear of a specific thing. What this means is that the person will avoid this thing and will be constantly thinking about potentially encountering this thing, causing them to change their social routines and impede on their normal social functioning. So once again, a criteria is not just being scared of something, it's that it has to interfere with their social or work functioning of a normal person. And you can imagine it doesn't matter necessarily what the person has a phobia toward. People can develop phobias toward very specific and very strange things, such as milk, for example. Here are some of the most common phobias. As you can imagine, spiders, flying, public spaces, enclosed spaces are common examples. One thing to consider is what would be the thinking and behavior of somebody, for example, who is claustrophobic. Maybe they have to visit a doctor's office, and the only way to get there is through an elevator. The elevator terrifies them, so the whole day before, the whole drive to the doctor's office, they're constantly thinking about, how am I going to get in that elevator? It's going to be terrible. It's going to be so scary. I don't think I can do it. And hopefully that doesn't cause them to skip their doctor's appointment. But then you can see how this fixation and thinking interferes on things that they need to do as a person in the world. We also have what's known as social anxiety disorder, or sometimes called social phobia. This is the fear of being judged negatively, the idea that people don't like you, people don't like what you're doing, they don't like what you're wearing, and then the corresponding behavior is avoiding social situations or avoiding personal attention. You don't want to speak out in class, you don't want to wear things that people will notice or comment on in public. We also have panic disorder. This is where somebody has episodes of intense panic. And if you think about somebody with GAD who's generally anxious, tightly wound, panic disorder is episodes of extreme panic. So much so that you may need to have plans for breathing into a paper bag to relax, plans to contact someone so they can come and give you a massage. And what's interesting is we don't necessarily know what causes panic attacks. All that we know is that panic disorder tends to emerge when someone is in constant or regular stressful situations. So for example, somebody's in a high stress job at work. They've been doing it for years, and all of a sudden they start to have these panic attacks. There's no way to get them to go away. There's no drugs you can take that will prevent the panic attacks, but one suggestion is remove the stress from your life, and over time the panic attacks tend to spread out further apart and eventually may go away completely. Finally, I wanted to discuss a little bit the stress disorders. So first we have acute stress. So let's say somebody has a traumatic event, whether it's engaging in combat in the military, or whether it is a rape or sexual assault, or whether it is an intense car accident. Acute stress would be in the weeks after the event, having difficulty sleeping, having difficulty going to places that normally you're comfortable going. Of course, there's going to be tension, there's going to be anxiety. Now contrast that with what's known as post-traumatic stress, or PTSD. Unlike acute stress, somebody with PTSD after the event might not look like they're showing any signs of stress. And what you want to be careful, whether this is you or whether this is your friends or family, someone experiences trauma and it looks like they're going about their lives just fine for the month afterward, you don't necessarily want to compliment them and say, it's amazing how great you're dealing with this. You're just so strong. Because in fact, not showing some acute stress after a traumatic event is a risk factor for later PTSD. And of course, neither of these is going to be pleasant, but PTSD is delayed, so you get that maybe half year or so where it seems like life is fine, I'm dealing with it, and then the PTSD intrudes with nightmares, intrusive memories that just pop into your memory system when you don't want them to come. And of course, acute stress, it's very difficult to deal with in the moment, but can last a couple weeks or months, whereas PTSD can last years and require intense or regular meetings with focus groups or counseling groups or therapists. I also wanted to look a little bit more into specifically social phobia or social anxiety. What kinds of things are most likely to elicit or start this anxiety popping up? As you can see, public speaking is a big one. Performance of a social interaction, you know you're going to have to meet and talk with somebody. Meeting new people, and especially parties, not as intense as some of these others. But you probably know someone, or maybe yourself, that has anxiety going to parties because it will involve many cues that could ramp up this social anxiety. What are the differences between these blue and red bars? The blue would be females and the red would be males. So as you can see, there's a clear gender difference, tilting much toward females in experiencing social anxiety disorder or social phobia. I also wanted to talk about PTSD just a little bit. PTSD has had a long history in terms of knowing that it's there, but it's only been formalized within the last few decades in terms of popular and common understanding of what it is. And I think when we look at PTSD research and presentation in pop culture, we still see a lot of misconceptions to this day. So I think the field of psychiatry and psychology is still understanding what this is and isn't. So I wouldn't be surprised if in future DSMs we see substantial revisions to PTSD. But it's important to see that general base rates, we look at the length of the deployment, seems to have a relationship to the incidence of PTSD. So for example, the longer you're involved in a combat zone, the more likely you are to experience PTSD. Whereas the Gulf War, shorter deployments, less PTSD. Now what's happening with Iraq and Afghanistan? Deployment is still pretty long, but the rates are lower than they were in Vietnam. I think you can quote this up to general increased awareness in terms of leaders and protocols. So for example, if somebody is in traumatic combat, then they'll be more likely, based on my understanding, to be put in a situation where they're less likely to experience combat. To give the time to see if acute stress shows and to hopefully prevent PTSD from forming. Of course, we also have to talk about suicide. So vets make up less than 10% of the population, but they account for 20% of its suicides. Part of this could be a gender imbalance. If there are more males in the military, well, they will be overrepresented in the suicides because males are more likely to commit suicide. But you could also argue there's something else going on too. These suicides, is it a consequence of seeing combat, or instead, is it a sign that perhaps we don't have the adequate support structures available and that we could improve this rate by better support for our vets? We also have OCD-related disorders, and that stands for obsessive compulsive disorder. This used to be categorized under the anxiety-related umbrella, but it was determined that OCD shares enough unique and distinctive features that it is distinct from an anxiety disorder. And as you can see, obsessions involve repetitive thoughts, and then the behavior that we see, or the actions, are the compulsions. Of course, we can see clear differences in brain functioning for obsessive compulsive disorder. So for example, if you have to walk into a door. Most of us would have no problem with that. But for some people with OCD, walking through doors is a traumatic deal. And you see tons of brain activity thinking about what it's going to be like, how am I going to do this, how do I need to set up my routine to be able to accomplish this goal of walking through a door. We also have body dysmorphic disorder. This is where somebody sees their body as being ugly or flawed in a way that other people wouldn't normally, reasonable people wouldn't judge it that way. And you can see that sort of like OCD, there's the fixation, the obsessions with your body and that flaw. The repetitive behaviors would be, for example, mirror checking, or in extreme versions, repeated plastic surgery. And related to both of these is hoarding disorder as well. As we all know, hoarding involves an attachment to personal possessions and an unwillingness to get rid of them, regardless of value. And you have, of course, the obsession with, I need this, this might be of use to me sometime, and the behavior, of course, is trying to find room for it and cramming it in your house. As you can see, common OCD obsessions are germs, fixation with something terrible likely to happen soon, or with symmetry or order. Everything has to be perfect. And you can see this categorizes most people with OCD. Then what is the compulsion that goes along with it? Of course, with obsession with cleanliness, you have continuous grooming. Going to the bathroom, washing hands, brushing teeth too much so they're damaging your gums. Q-tipping is a common compulsion. People Q-tip too much and it actually removes too much wax and becomes unhygienic. And of course then here's the common OCD that we see as repeated rituals. So for some people it might take them 5 minutes to get into and out of a door. If you have tons of rituals, it might take you 4 hours to get up and get cleaned and eat and leave your house. And of course, if it's taking that long to do your rituals, it is clearly interfering with your daily life. And of course, think about checking doors or locks. I know a lot of times I think, am I forgetting something? Did I lock my car? I'm halfway to school and I'll walk back and check. Does that mean I have OCD? Probably not. It has to substantially interfere with my life, my job, my social functioning. And if it doesn't, that gives us a taste of what it might be like to have this disorder, but it doesn't mean that we're clinically over the threshold for having it. I'd like to transition into mood disorders. And mood disorders have a strong comorbidity or are likely to co-occur with anxiety disorders, meaning that if you have one, you are statistically more likely to have the other as well. As you can see, mood disorders are characterized by emotions. Emotions we tend to think of as more short-term. We experience many emotional states in the course of a day. A mood is generally more persistent. With depression, we won't go into detail with all the different kinds of depression. Many people are likely to have some depression at some point as a consequence of something bad happening to you. The depression that most of us might experience is different from major depressive disorder. This is like what we know of depression, except in extreme form. So you have to have 2+ weeks of extreme depressed mood, feeling worthless, no interest in your activities that normally you take pleasure in. You can even have some psychomotor retardation. It's hard to move, physically hard to get out of bed. Also delusions that you're worthless, that you smell, that you're evil. And those are some of the features that somebody with major depressive disorder might show. A different but related kind of mood disorder is known as bipolar disorder, formerly known as manic depressive, because it was thought that you would alternate between the manic hyperactive state versus the depressive low energy state. However, it's now known as bipolar because the poles and their extremes can range drastically between two different people with a disorder. So for example, some people whose manic state is yours and my regular state would then cycle down to a very severe depressive state. It could also be the case that somebody whose normal state is what we would consider a depressive state, and their manic state is extremely hyperactive. As you can see on the slide, manic episode is a characteristic feature of many forms of bipolar, but again, not all. And this is characteristic of hyperactivity, unrealistic optimism, and overly excitability. What this means is that somebody who is in a manic episode is very optimistic, believes that they can accomplish basically anything. They are seeing things that not other people can see. They also are very likely to overspend. There's many cases of people who have maxed out their credit cards in a manic episode and bought maybe 20 DVD players, for example. And as another example of how we may not have a psychological disorder, but we may have experienced what it's like, or just a taste of what it might be like. I can think of a time where I've been in sort of a quasi-manic state. I was moving into a new house and doing a lot of work there. I was teaching overload on my classes at work, and I had other things going on as well as far as committee work and research. I was doing all this stuff, and each box I crossed off felt really good. And I thought that I could keep going. I could sleep less. I could keep moving. Unfortunately, of course, I crashed after a couple weeks of doing this. Now, the problem with bipolar is that somebody may have to go for a long time in a manic episode before the crash. Now, finally, it's important to distinguish that bipolar disorder is different from somebody who we might characterize as moody. For example, somebody who is angry one day and then nice and relaxed and then anxious and hyperactive the following day. That's different from bipolar. The vast majority of cases, except for the rapid cycling variant, will take a while to cycle between the depressive and the manic states. So what you see is a way to sort of predict or get a feel for when somebody is going down into the depressive state or up into the manic state. It's important to think about bipolar because it's being diagnosed more and more. And I think there's more research to do to understand what exactly is the base rate of bipolar. So I think there's some classic examples of bipolar. You know, somebody who cycles up and cycles down, and you can see that it corresponds to different brain activity. And then there's also some different subtypes of bipolar that we won't get into. And I think more research is needed to be done on this. So for example, a child who's diagnosed with ADHD, and the treatment doesn't seem to necessarily help or fit, then they might later be diagnosed with bipolar instead. It's those diagnoses that I still think we need more research into understanding. And once again, when we're diagnosing children, we need to have specific research to show that that disorder occurs in children and that diagnosing it has some benefit toward leading them into treatment that benefits them. Once again, and this is the case with all psychological disorders, but we'll stick with depression for this example, we need to consider different ways that a disorder might express itself across cultures. And here you can see, looking at different countries, there are vastly different rates of diagnosed depression. The general pattern is that females are more likely than males to be diagnosed, but you could also argue that this might not be a real difference, but instead a reduction in males' willingness to perhaps accept that they might have depression and a willingness to go seek help and get a diagnosis. You can also see one exception, Puerto Rico. What's happening there? Why are males more likely to experience depression? Well, I've had some students who have lived in Puerto Rico tell me that, unlike the US and many other countries, the men are less likely to be working. They're more likely to be on the street in cafes, playing games, or drinking tea or coffee. And the women are working. And you can argue that work centrality could be a big boost to self-esteem and maybe a protective factor against things like depression. So once again, many examples of cultural or environmental forces that can influence the base rates or the expression of a potential disorder. We also want to look at how depression changes across the lifespan. And the good news is that as we age, our likelihood to develop depression goes down. So again, lots of things will happen when we get older that we don't look forward to, but one would be we're less likely to be depressed. The gender difference stays, but tends to get reduced. And then, of course, at the very end of the lifespan, we see that it actually flips and males are more likely to be depressed. Although, again, the base rate is actually pretty low. But one consequence of depression is suicide. And we can see that males, in fact, are more likely to commit suicide than females. Females may be more likely to attempt suicide, but males are more likely to carry it out successfully. And we see at this retirement age for males, again, going to the issue that work and work centrality to someone's value as an individual might be hugely important. We see the risk of suicide spike greatly in elderly men, for example. So that means if you know someone who's retiring, you might just want to check up on them and see if they want to go see a movie, want to go out to eat, because that could be a key time where they might be contemplating things like this. And of course, we think depression is strongly linked to suicide, and it is, but not to the extent that most of us would probably guess. So we see 13 to 41% people who commit suicide but would not meet the criteria to be diagnosed with depression. So there are other disorders that we also need to think about besides depression, such as panic disorder, social phobia, especially borderline personality, schizophrenia, and substance abuse, that could be linked to somebody's risk for committing suicide and attempting suicide as well. If we think about depression, this is a continuation of a theme we've talked about before. Bad things happen. If we have low self-efficacy about that, it doesn't matter what we do, life is stacked against us, we will feel lowered mood and will tend to act and think in a way that reinforces this mood, causing a negative cycle, right? So social cognitive perspective would say the therapist needs to step in somewhere, right? The drugs, for example, or medications could treat the mood, or we could have some therapy to change the way the person thinks about their situation, give them some goals that you'll follow up on to make sure that they're changing their behavior in positive ways. And of course, like many things, when other people are being irrational, like Charlie Brown, we can see it for what it is and say, that is not rational, that's not what's really happening here. But of course, when it's us, it's much harder for us to introspect and accurately understand what's happening and why it's happening. And so in many cases, the simple act of talking to someone and have them pointing out our irrational thoughts might have a big effect in preventing potential depression. Now we move into the generally pretty serious and more rare dissociative disorders. With a dissociative disorder, you separate in some ways your consciousness from either previous memories or who you are. So first of all, we have dissociative identity disorder, formerly known as multiple personality. This has been one of the most controversial diagnoses in psychology. It's typically believed that some people have dissociative identity disorder, but it's so rare that it becomes difficult to get a big enough sample or population to have the kind of faith in the diagnostic criteria that we would have for some of the other anxiety and mood disorders we've talked about. So I think one thing to remember is that with dissociative identity disorder, it's pretty rare, and there have also been many notable cases where it seems that people have been faking it. The one thing to remember from dissociative identity, on the other hand, is what causes it. We don't know exactly, but most of the confirmed cases that we do believe it's there have been linked to some sort of childhood trauma, either sexual trauma or verbal or social abuse. So one more reason that we want to prevent childhood trauma, because we certainly don't want them to develop dissociative identity disorder. Even if it's unlikely, we need to take steps to avoid that. We also have the memory-related dissociative disorders. So we have dissociative amnesia. This is where you tend to lose memory of previous events. It's usually temporary, but it might come back in bits and pieces. And we've also, with dissociative amnesia, eliminated brain trauma or brain injury as the reason for this. In some ways, the person might actually experience what Freud called repression. It's important to note that this would be very rare as well. It has to be usually pretty traumatic and a very abnormal way of dealing with trauma for someone to develop dissociative amnesia. And one way to sort of bring these memories back might be to take them back to childhood homes or objects or things that they used as children to bring back or cue those memories. We also have dissociative fugue. This is a temporary loss of a previous identity, such as in The Majestic, where somebody wakes up in a cornfield, walks into the town closest and has no idea who they are and picks up a new identity. Once again, this is also quite rare. Some dissociative fugues in the past have been ruled out because it was due to taking too many drugs. But once in a while, you do have people who just walk away from their lives and seemingly, and usually not for too long, it's days or weeks or maybe a month, assume a new identity and then sort of snap out and come back. So again, it's very rare for somebody to have dissociative fugue for the rest of their life. It usually will come back and their previous identity will be restored. And then finally, we have schizophrenia. Some people might confuse schizophrenia with multiple personality or dissociative identity disorder. It's important to distinguish that schizophrenia is substantially different. There is some dissociation, and that's the term split mind as the etiology or origin of the word. One biological factor that is key for schizophrenia, that is almost universal in cases of schizophrenia, is overactivity of dopamine receptors. And unlike many other psychological disorders, schizophrenia has clear biological links. And I think we're going to find out clear genetic origins as well. What we see with schizophrenia are delusions, false beliefs, things that aren't true, and hallucinations, seeing or feeling or hearing things that aren't there. It also involves weird regulation and inappropriate expression of emotions and behavior. Of course, we can see characteristic brain activity. Someone with schizophrenia who's looking at the same object as somebody without schizophrenia might be hallucinating here, as we see activity in their occipital lobe. Also, what are some of the risk factors for schizophrenia? Well, drug use can be one of them. So we look at the number of, or the amount of consumption of cannabis, for example, and we see that the more times you consume cannabis, it is increasing your risk of later developing schizophrenia. If you look at the rate here, it's not a huge risk, but once again, we're going to show a lot of potential links to schizophrenia. And if you have one of them, that means you need to protect yourself by lowering your risk for the other ones. Continuing our discussion, delusions are false beliefs, often of persecution. People are out to get me, or grandeur. I'm a superhero. I can take you down. Also, we have hallucinations. These are sensory experiences that have no external origin. And so, for example, if you see Peter Pan jumping out of your peanut butter jar, that would be a clear hallucination. I think what's important to distinguish is that with video games, for example, I used to play a lot of Tetris, and there are times where I'd be thinking about it and walking around and actually seeing blocks falling in my visual field. I think a lot of alien encounters or seeing ghosts could often be attributed more accurately to hallucinations, maybe times where we're in between REM sleep and wakefulness. So once again, hallucination by itself is not enough to say schizophrenia, because many of us might have experienced hallucinations in the past or in the future. We also look at what are some things that are linked to schizophrenia. Unlike many other psychological disorders, there's been tons of research and things linked, but for schizophrenia, there's lots of weird links that don't necessarily seem to make sense, right? So when you're born in the winter versus the summer, if your mother had the flu when she was carrying you, if you're born in an urban environment, if you've experienced some of these difficulties prenatally or as a newborn, those all tend to increase your risk of developing schizophrenia, but they're far from guarantees. So what this seems to mean is that with schizophrenia, there's going to be a clear genetic link, but that's not necessarily a guarantee by any means. So for example, if you have a genetic link or some of these prenatal complications, that means you need to be especially protective against abusing drugs or stress. And these things definitely seem to be able to push someone over who's susceptible for schizophrenia into a full diagnosed case in early adulthood, oftentimes. It's also important to realize that schizophrenia can play out differently for different people. So we see that some people have a schizophrenic episode, usually then receive treatment, often drugs, and then go back to their previous level of functioning. We have this other group who may need treatment, get back to their previous level of functioning, but then things go off the rails a little bit. They need to get attention, but then go back to normal, right? We also have group 3 after the first episode, and this is the least likely group. They never go back to their original level of functioning, but they can keep getting back to their new baseline. Unfortunately, though, we see that over a third of patients, with each treatment, they form a new, less good baseline. And this seems to be slowly spiraling into a level of functioning that will require more help, more assistance, more care from the system or from friends and family. Here we see some historical and pop cultural examples of people who have been diagnosed with schizophrenia. First of all, we have John Nash, second author Jack Kerouac, and also musician Syd Barrett. Syd Barrett was the founder of Pink Floyd, the psychedelic band, and he's a classic case of somebody who just took too much acid and then pushed him into schizophrenia, and he never came back. John Nash is an interesting story because he's one of the only documented cases that I know of that was able to eventually live his life, work at a job, be a husband and father, while not taking any meds for his schizophrenia. And it took him his whole life. He had to be hospitalized a few times. It almost cost him his marriage. And I think one important factor for anybody with a psychological disorder is the social support they get. And his wife stood by him the whole time. And I doubt that without his wife, without his loving family, accepting him and trying to help him, would he be able to survive and function without medication. And this is an issue that you can apply to any psychological disorder because caregivers are often at risk for burnout. Things can go on for 5 years, 10 years, and then they've just had enough and can't support this person anymore. And then what then? Is there a system or facilities that can take care of this person and provide maybe what the burned out family members are no longer able to do? We also have different types of schizophrenia. This is less for the exam and more just for personal interest. So we have the paranoid schizophrenic, always believe that someone's out to get them. We have the disorganized, and they have very strange and inappropriate speech and behavior. You might go to shake their hand and they slap you on the face, or you might tell them that your dog is sick and they'll laugh. Catatonic, difficulty moving. Severe catatonic schizophrenics might sit in a corner and do basic repetitive moving. You try to have a conversation and they might just repeat certain words that you say. And then you have undifferentiated, where they just don't really fit any of the other types. And so with the new DSM, since the treatment doesn't differ based on what subtype you have, this is typically not something we use anymore today as of 2013. We also can see the genetic risk. So of course, the general population, about 1%, and this seems to be pretty consistent and universal across different cultures. So schizophrenia is fairly unique that the base rate seems to be very consistent. The more genetic material you share with someone, moving up to identical twins, the more likely, if your twin has schizophrenia, that you will be diagnosed. But the good news is that it's still under 50%. So if you have an identical twin who's diagnosed with schizophrenia, I would certainly try and find a very low stress job and avoid psychedelic drugs. And that might be enough to prevent me from fulfilling my genetic predisposition towards schizophrenia. One interesting thing to try and see in the mind of somebody with schizophrenia is their art. And so let's assume that this was just a general picture of a soldier. And there's many examples where a normal person would draw a normal looking picture. But this is how the person with schizophrenia sees what looks to everybody else as normal. And just goes to show that the disorganization is in such a way that it's really hard to understand what they're thinking and why they're thinking it. And our last general class of disorders will be personality disorders. Just like personality in general that we've discussed, it's a fairly consistent way of thinking and behaving. It is also without the other features of some of the other classes of disorders. So what this means is that personality disorders kind of stand alone. And also, since you can't really change someone's personality, the therapy options for personality disorders are different from many other disorders. Drugs may be expected to have less of an impact. Certain types of therapy, once again, because you can't change someone's personality, might not work as well. So basically, personality disorders involve a somewhat unique set of circumstances compared to the other disorders we've talked about. So first we'll cover, perhaps the most important one socially, is antisocial personality. It's a person, and males are about 5 to 10 times more likely than females to have antisocial personality, who do lack what we call a conscience. They don't feel remorse or guilt when bad things are done to other people or when they do bad things to people themselves. We can tie this to frontal lobe activation, whereas if we're watching violence or aggressive sexual scenes, our prefrontal cortex, our frontal lobe will be lighting up because we're distressed by what we're seeing. That just doesn't happen with people who have antisocial personality disorder, whether it's Hannibal Lecter, somebody like the Joker, who loves chaos, loves messing with people, feels no remorse for destroying things, or Anton Chigurh from No Country for Old Men, a hired killer who doesn't have any problem killing anybody in his way, and in fact likes to make games out of it because he finds that entertaining. Of course, it's not just violence. It can also be economic antisocial behavior. So conning an old lady out of her life savings, for example. And you could also argue that some of the people in major Wall Street banks show some signs of antisocial personality disorder. They function to make as much money as they possibly can, and they don't seem to care if it brings down the economic system. They don't care if people lose their health care or, for example, don't have jobs or have lost their retirement savings because they don't feel that guilt. And so I think in the future, I'd like to have increased discussion of how antisocial personality affects our economy and our government, because I suspect that there's more there than we commonly acknowledge. Once again, we can see those with antisocial personality will show difficulty with morality, controlling impulses. It'll be tough for them to get close. Also, there's signs usually in childhood, sometimes, and this has been overstated, but there's some truth to it, abusing siblings, pushing down your sister, and you ask why? Just because I wanted to see what would happen. Abusing animals, torturing animals, and starting fires. So if you know somebody who's a child and is doing those behaviors, it might be time to intervene before something really bad potentially happens. And once again, you can see normal activation for watching a violent scene, almost nothing. This could be similar to if they were watching an opera versus aggressive violence. We also have many other personality disorders. I won't cover them all, but I wanted to introduce some that I think are relevant and that we've seen examples of and might deal with in our lifetimes. So first of all, we have schizotypal, which sounds like schizophrenia, and in fact is like schizophrenia in terms of thinking and acting, but without the delusions or hallucinations and the corresponding differences in the dopamine pathways that are characteristic of schizophrenia. So if you've ever seen the movie, classic movie Taxi Driver, the main character has some very bizarre thoughts, some very bizarre beliefs about how the world works, and most people, most reasonable people, would not share those beliefs. We also have borderline personality. Been a lot of research into this, and it has evolved over the 5 or 6 decades since it first came out. Amy Winehouse would be a classic example of borderline. Marilyn Monroe is also put out as a classic example. They don't necessarily, it's tough to know who the real person is. They vary their looks, their behavior a lot to fit in with who they're with. We also have some, what I like to call, social personality disorders. So we have the schizoid personality. This is, if you've heard of the term misanthrope or misanthropy, this is a hatred of humanity. So I haven't read much Kafka before, but he has a very mechanical view of humanity. It's not very sympathetic. It's a view of we're just ants in an anthill, or we're just cogs in a giant machine, and it doesn't matter what we think, it doesn't matter how we feel. And I think what this means is, if you had a schizoid personality disorder person as your neighbor, I would probably just leave that person alone. They may not be dangerous, but the social interaction will not be pleasant. You can also have what are called avoidant personality disorder. They like to be alone, but they generally have warm feelings to people. It's often thought that Michael Jackson showed symptoms of avoidant personality. And so again, if he was your neighbor, I'd leave him alone, but I wouldn't feel scared if my dog wandered into his yard, for example. So we've covered lots of different psychological disorders, and there are hundreds more in the DSM that we can't cover. And so I think what we need to keep in mind is there is a psychological phenomenon that the more we learn about psychological disorders, the more that we think we have them. And so we have to take a step back and realize self-diagnosis is a bad idea. Self-diagnosis might be a good way to go see a professional. It might be the kick in the butt we need. But self-diagnosis by itself is more dangerous than helpful. We can also look at some of the general base rates broken down between ethnicity and gender. And perhaps not surprisingly, the most common we see is alcohol abuse, substance abuse, coupled with phobias. Now, I think I'm surprised to see that antisocial personality is so common. Schizophrenia, right around 1 to 2%, and OCD is pretty low. And I think this is one to keep in mind. A lot of people think they have OCD or that their friends or family have it. Chances are statistically that they are not clinically diagnosable, even though you might see some similarities in how they act. Instead of looking at percentages, let's perhaps look at the total numbers in millions in the US of having psychological disorders. Bipolar, 5 million, and you can see social phobia is way up there with even major depressive disorder. And once again, schizophrenia would probably be right down in this area as about 1% of the population. So when we say that maybe 20% of the US population could use some sort of psychological services to deal with a disorder, you see these numbers add up pretty quickly to even over 20% of the US population. But of course, we have to consider that some people in here, a fair percentage, will have multiple diagnoses. Quick review. What might cause generalized anxiety disorder? Typically doesn't have link to childhood stuff, but instead it is exposure to unpredictable aversive events. I don't know about you, but I've been in some situations where a bad thing happens, and then another bad thing happens. And for the next few weeks, I'm just tense because I'm expecting more bad things to happen. Generalized anxiety disorder is like that, except persistent. We haven't talked specifically about anorexia, but it happens in the US much, much more often than other cultures in the world, specifically sub-Saharan Africa, where food is very short compared to in the US. What would not be able to explain this? Well, medically, genetically, we're not that different in the US compared to sub-Saharan Africa, and the medical perspective couldn't account for that. What could, instead, is the biopsychosocial. So it's not necessarily your genetics that explain anorexia, but how you think about food and what is your society and your peer group and your family telling you about body types and what's ideal and what is not ideal. So we have Chet. He doesn't take enough credit for his achievements, and he takes too much blame for his failures. Going back to our perspectives, what is the rational, common sense one? Come on, Chet. You actually had a lot to do with this success, and you should feel good about it. Take credit for it. That would be the social, cognitive, rational, common sense perspective. Patterns of behavior and thinking that emerge sort of during or stabilize during adolescence and really have difficulty in terms of treatment, at least large treatment effects. As you might have guessed, this would be personality disorders. What is the goal of the DSM? It's not always in terms of describing causes. It's not really looking at normal. They're not wrong, but the best answer is the goal is we provide the criteria. These are the things that are most strongly linked to whether the disorder is there or not. So this will be the OCD question because we have the behaviors and the thoughts. And of course, the behavior is the compulsion, repeatedly going by your stove a dozen times in the morning to make sure it's off, and then thinking while you're sitting in your living room that you might burn down your house is the obsession. Quick true false as we start to wrap things up. This would not be a false belief, a hallucination. Instead, it would be what we call a delusion. Does the US still have a number of asylums, like in the 50s and 60s, storehouses for people with mental illness? Generally not. There might be some that function kind of like that, but they're typically only available to people who have a lot of money to pay for them. And in fact, most people will go in for inpatient treatment and then have to leave a couple weeks or a month later. Sometimes you can argue before maybe their primary symptoms have been fully treated. So we might have a capacity problem. This is very true. Many psychological disorders, once you're diagnosed with one, you increase your likelihood of being diagnosed with another. Specifically, depression and types of anxiety disorders are likely to be comorbid. Social anxiety disorder and avoidant personality disorder, the behavior might look very similar, but they definitely are not the same thing. Social anxiety will have a lot of corresponding anxiety. The avoidant might not experience tons of anxiety, they just don't enjoy being around people. There's an argument that some psychotherapy works due to the placebo effect. If somebody goes to therapy, they expect that they're not wasting their time, that something good's going to happen, and they feel better. This is false. So once again, for a treatment to work in terms of an evidence-based approach, we have to show not only that people feel better than the people who don't get any treatment, we have to show that people feel better with this treatment compared to a placebo group who thinks they're getting the real treatment. And that's when we really know that something useful is there. This is a common belief that since schizophrenia is called a split mind, that people with schizophrenia have multiple personality. This is not true. In fact, people with schizophrenia are distinct in having hallucinations and delusions, whereas people with dissociative identity disorder are not necessarily having hallucinations. You could argue that having different personalities in one body seems like a delusion, but they also don't have the corresponding physiological or dopamine differences like people with schizophrenia do. And today for our key study, I'm coming back to Scott Lilienfeld, again, one of my favorite clinical psychologists. And you can see some of the arguments about we don't want to throw the whole system of using the DSM out, but instead of perhaps just revising it every couple decades or decade or so, maybe we should instead come up with a new system that takes the best parts of the DSM, but also is adaptable to the realities of psychological disorder. And some of the arguments here, I won't point out to all of these, is that we have the comorbidity problem, meaning there's a lot of symptoms for different psychological disorders that are the same. And that seems to mean that maybe just our system of diagnosing one, seeing how it works, and then maybe coming back and modifying that diagnosis if it doesn't fit, might be able to be improved. So here's how Scott Lilienfeld perhaps suggests diagnosing at some point in the process psychological disorders. And what I think is interesting is that in here you can have this general scorecard that would be used for any psychological disorder. And we can first look at, is it a genetic test, and what is that gene linked to? Is it memory or attention, or is it social processing, for example, or anxiety related symptoms? Or we can look at maybe blood tests, for example. We can look at circuits in the brain. We can look at measures of heart rate, and of course behavior and what do people tell us, right? And once we be able to use the exact same variables for each psychological disorder, we would have a more systematic way of understanding the overlaps and the true differences of psychological disorders. So once again, I'm not a clinical psychologist. I don't know the details, and I'm not in on the newest additions to this debate. But I'd be interested to see how this is integrated moving forward, and if the American psychiatric community accepts this or continues with the status quo. But that's enough for now. We've covered a lot of material, so let's discuss it. What does this fit with what you know about psychological disorders, and where have you seen some of these things play out in your family, in the media, or in how our legal or criminal justice system is set up? What do you think is good or bad about the way we do this process? What do you think about the future? What would you like to see for the future? Would you like to see more or less brain imaging or blood test or genetic test in the diagnostic process? Looking forward to discuss this and more on the discussion boards.